Hi, everyone. Welcome to my webinar on knee and hip osteoarthritis. My name is Chris Kennedy, and I'm a physiotherapist with InReach Online Physio. Just a quick bit about InReach. It was established in 2018 by myself and my colleague, Aaron Doby, with the aim of providing physiotherapy services to people throughout BC in rural and remote areas, but also people who prefer not to leave their home for a variety of reasons. The concept of a virtual physiotherapy may seem a little bit odd to some of you, but there's a lot that we can provide virtually: education, exercises, some advice on things to do and not do. So yeah, it's been great over the past few years to work with people from all over British Columbia, and our team has grown in that time to a collection of 9 physiotherapists who are able to provide a wide range of services and who have a range of expertise in a variety of areas. There's a little bit about myself. Essentially, my journey has led me here has resulted from essentially a desire to help people do what they want to do. I have a background in personal training and strength and conditioning, and as I worked in that area for a number of years, I became to realize that osteoarthritis was a major issue that prevents people from doing the things that they want to do and affects their life, and that led me to try to develop more experience and further my education in that area. And that's what I hope to share with you here in this webinar. So this webinar will be about 30 minutes long. I'm going to talk about what osteoarthritis is, some myths and facts about it, and ultimately what we can do about it. And this is a recording of the it's not the live version, so there won't be any questions at the end. But if you do watch this and you do have any questions, feel free to get in touch with us at InReach, and would be more than happy to address any questions you might have. Quick disclaimer. So even though a lot of the information I'm going to be providing here, I think is appropriate for a wide range of people, it needs to be said that it's best to speak with your care provider, your physiotherapist, or your doctor, perhaps, about if implementing any of these recommendations are appropriate for you. So because these treatment plans should be individualized based on the specifics of the individual. Okay, so what is osteoarthritis? It is commonly referred to as OA. I'll be referring to it as OA a lot throughout this presentation. And it's the most common cause of difficulties with mobility and disability in older people, with it affecting approximately 30% of people between the ages of 50 and 70, and it increases in older age groups. But it's also common in people who are younger, and less common, but many of those people who have OA, they have injured their joint in some way earlier in life, in most cases. Okay, and the problem with osteoarthritis is that it results in a cycle like this. So it can be painful, and that pain can lead to inactivity. And the inactivity can lead to some deconditioning. So deconditioning of some of the muscles that would protect a joint affected by OA. It can generally make the individual less healthy. And we'll learn a lot of those things can drive some increased pain. And again, around and around we go. More pain, less activity. And yeah, this is the cycle that we want to break, and we'll talk about that as we go here. So when we talk about osteoarthritis, the main structure that's affected by OA is the cartilage that lines at the ends of the bones, but all of the joint structures are impacted by OA. So the synovial fluid, which is an egg-like egg white-like substance in the knee. We retain a good amount of that throughout our lifetime, but it is influenced by OA also, in addition to the synovial membrane, which is basically the joint capsule, which contains the synovial fluid. In addition to the ends of the bones can also experience some changes with OA. So it's an entire joint issue. And some of the signs and symptoms of OA can include pain and stiffness, along with decreased range of motion. And if there is swelling, it tends to be only mild with OA. And I just want to make this quick note that OA is different than osteoporosis. So osteoarthritis and osteoporosis are oftentimes confused, or the terms are used interchangeably sometimes, but they are quite different because osteoarthritis involves the joints, so the ends of bones, where two bones come together, whereas osteoporosis affects the bones themselves, and it's essentially characterized by decreased bone density. Now, there are over 100 different types of arthritis, and when some people say, I mean, when you hear the word arthritis, sometimes it's not as specific as it could be, because we're just going to be talking about osteoarthritis. So over on the left there in the green, that's the only type of arthritis we're going to be discussing here. But even though it is only one type, it is by far the most common. And then there are a variety of types of inflammatory arthritis, so including rheumatoid arthritis, psoriatic arthritis. Some of those are the more common types, but there are many others in that category. And that would be where a rheumatologist is a type of doctor that specializes in those conditions. And then there is something called septic arthritis, which is an infection of the joint. We're not going to be talking about that. That is a medical emergency, but I just wanted to make you aware that that is another type of arthritis. So how is OA diagnosed? Well, we use a variety of things to essentially end at the diagnosis of whether or not someone has OA or doesn't have OA, and if they do, the extent of it. So we use a combination of the description of the symptoms, such as when does the pain come on, how long does it last, in addition to the location of the pain and the pattern of the pain, referral patterns, those sorts of things. So those give us all clues as to what may be the cause of someone's pain. And then we use a clinical exam, which may include some functional tests, so standing up and down from a chair, how someone's walking, checking some muscle strength, and looking at range of motion of the joint in question. And then most of us probably think of just the X-ray as being the most conclusive way to determine the presence of OA. And certainly we like to get as much information as possible, so it's helpful to get an X-ray, but it doesn't tell us the whole story, as we'll learn, because there can be a disconnect between what shows up on an X-ray and how someone feels. So for example, someone can have quite advanced OA on an X-ray, but functionally and pain-wise, they're quite good. They're not experiencing much pain. So we'll talk a little bit more about that. And I just quickly want to touch on some of the risk factors for OA. As I mentioned earlier, increasing age can be a risk factor, along with gender. It's more common in women. There are some genetic factors that are connected to OA. Previous joint injury or disease, some occupations that involve compromised positions or repetitive tasks. There's some metabolic disorders that are associated with OA, such as diabetes. Loss of strength in the muscles supporting a joint is a risk factor that we're going to talk a lot more about, including excess body weight. Okay, so some of those things we can't change, but some we can, and we'll be touching more on those. Okay, now in part two, I'm going to run through some myths and facts related to OA. So number one, OA is caused by wear and tear. So we commonly hear that. but it's a myth because it's misleading. So cartilage actually needs ongoing movement to stay healthy. In a healthy joint, there's a balance between buildup and breakdown of cartilage. This is why healthy loads need to be applied on joints for cartilage recovery. So viewed through that lens, it should be more this wear and repair instead of a wear and tear. So, for example, it's been it's known that orcas or killer whales who live in captivity have a higher incidence of what's called dorsal fin collapse, and their dorsal fins are comprised mainly of cartilage. And one of the leading theories is that these orcas who live in captivity, they aren't swimming as far or as fast, or experiencing the forces on their dorsal fin as much as the orcas in the wild. Now, I need to mention that apparently this occurs in orcas in the wild also, the dorsal fin collapse, but not as high of as an incidence as the orcas in captivity. So those forces, the mechanical forces on the fins, they keep them strong and healthy, and that's a similar experience as what happens in our joints when we keep the joints moving, load the cartilage. But I need to be clear here, although we're optimizing the health of whatever cartilage there is, the buildup is not, we're not building new cartilage, we're just building up and strengthening the cartilage that's there. Okay, so currently we don't have any way to build new cartilage when there's been some cartilage loss, but we do know that we can optimize the health of cartilage by getting that right amount of movement and exercise. OA is always painful. That's a myth. So there's a lot of research that has shown that the amount of OA that would show up on an X-ray is not correlated with the amount of pain that someone feels. So those changes just increase your chances of having pain, but they don't mean you're doomed to have pain. Strong muscles can ease away pain, so that's a fact. Because if we build up the muscles around our joints, we'll help protect the joints, stabilize them, make them less vulnerable to injury. We're going to be talking a lot more about that a little later. Now, running will wear out your joints and cause OA. So that's a myth. There's been some good research, long-term studies that have shown that the incidence of OA in runners is not any higher when compared to non-runners. But if you look at that chart on the diagram on the left there, you'll see that recreational runners compared to non-runners and competitive runners, the recreational runners do the best when related to OA. The competitive runners, they found that those individuals would be running more than 92 kilometers per week, over an extended period of time. So that's quite a bit of running. So what we can take from that is that there's sort of this bell curve type of scenario where there's a good healthy amount of running that can be done that does promote joint health. It doesn't lead to higher risk of OA. So if you're running currently, then you can be confident in that you're not doing yourself any harm by doing a amount of recreational running. Doesn't mean that you should start running if you're not already, but this is just good to know. You can't prevent OA. So that's a myth, because as we talked about those risk factors, well, there's some things that we can't change, like your age or that old injury from high school, but you can lower your chances in other ways by keeping the cartilage healthy, by getting regular physical activity and staying at a healthy weight. And if you already have OA, you can slow down the damage and you can lower your chances of more serious joint problems later if you adopt some of those risk mitigating strategies. Losing just a few pounds can help with OA symptoms. So yes, that's true. And research has shown that doesn't need to be a huge amount of weight loss. Even 10% of your body weight can ease OA pain by 50%. So that's pretty significant. So something that certainly needs to be considered. Osteoarthritis isn't a serious health problem. So that's a myth because, well, since OA is so common, its effects can often be or it can often be downplayed. But it is a big deal because it makes it harder for us to get around. It can keep us from working and doing the things that we love, and it can affect our quality of life. So it is a serious health problem, and so that's why we need to know how to best deal with it, and that's what we're going to be talking about here next. Okay, so in part three, I'm going to be talking about some of the treatments available for OA. And just at the bottom there, I've written currently there's no way of curing cartilage loss. So treatment is used to reduce symptoms and improve the function of the joint. So at the base of the pyramid here, the first line treatment that everybody with OA should receive, regardless of the level of OA, whether it's early OA, moderate, or more advanced OA. The base of the first line treatment should include education, exercise, and weight control. I'm going to touch on each of those. Second line treatment, after those first line treatments have been provided, would be pharmacological pain relief. So that would be things like pain medication, whether they're over the counter or prescription pain medication. So that would be something that would be discussed with your primary care provider, or such as your doctor. There are some aids that can be used, some knee braces, some gait aids like canes or crutches, those sorts of things. And then there can be some passive treatments provided by a therapist. So those could be provided by a physiotherapist or perhaps a massage therapist. But I'm going to talk more about those. And then surgery at the top. So that's a third line treatment. So that's reserved for the fewest amount of people with OA. And I'm not going to talk a whole lot more about surgery, but I'm going to go through those first two levels of the pyramid and explain a bit more. Okay, so with exercise, I'm going to start with this broad overview here. So we have something called the Canadian Physical Activity Guidelines, which is similar to physical activity guidelines in a lot of other countries. They're generally provided by the World Health Organization. And in this category here, 18 to 64, these recommendations are pretty much identical to 65 and above. But in that age group, 65 and above, there's an additional criteria of adding some balance exercises, which is very important to maintain our balance as we get older. But just to look at these different suggestions in the 18 to 64 category, we've got a recommendation of 150 minutes of moderate to vigorous aerobic physical activity per week. And that could be a wide variety of activities. That could be walking briskly, biking, swimming, could be running, a whole bunch of different things to make up that 150 minutes per week. And then there's the second category there of bone and muscle strengthening activities, at least 2 days a week. And those are sort of the minimum. As you can see, it says more physical activity provides greater health benefits. So if you're exceeding those numbers, then you're going to get more health benefit. And they found that these guidelines are appropriate for everyone, regardless of if it was OA or not. So when it comes to exercise options, research has shown that there are a variety of types of exercises that can be beneficial for OA. So that's great because that gives us lots of options to choose what we want to do for our exercise. Because one of the most important things is that we do something that we like, that increases the chances that we'll continue on with it. And because studies have shown that as opposed to the type of exercise that's done, more important than that is the duration that it goes on for. So when you plan to embark on an exercise program, you want to be approaching it with the intent of continuing on with it for a long period of time. So months, 3 months, 6 months and beyond, because it's been shown that it requires those longer durations to really experience a significant benefit from the exercise. Now, oftentimes physical activity is underutilized because of a fear of disease acceleration. But the research is clear and consistent in this area, that it's safe, it doesn't cause more joint degeneration, and on average, it decreases pain by 25 to 40%. So if we can make exercise part of our lifestyle, if we can find ways to navigate the pain, there's some pain that might be associated with exercise, we're likely going to experience some good benefits from that. So in regards to pain during exercise, because it can be common to have pain during exercise with OA, um, we have some guidelines to go by. So we can use this traffic light analogy, and as you can see, they're number one on that list: pain during exercise. So if you're doing exercise and you have pain that is 0 to 3 out of 10, we can be pretty confident that that's a safe amount of pain. If the pain creeps up to a 4 to 5 out of 10 pain, that can be acceptable. That's a bit more of a case by case basis. And 6 out of 10 pain, that would be kind of a no-go zone where you don't want to be experiencing pain at those levels. And if you do, yeah, you would want to, um, you know, talk with someone about that. Talk with your physiotherapist about that. But yeah, if you're experiencing that level of pain during exercise, you would want to stop it. And then the next criteria is the symptom response over the next 24 hours. So if you do experience some pain during exercise, whether it's in the 0 to 3 or the 4 to 5 zone, but it drops back down to whatever your baseline is within 24 hours. So you wake up the next morning and everything feels the same as it usually does. Then that means that your joint tolerated whatever that exercise was well, and it would be safe to continue on with that. If you have some increased pain the next day, then you would want to make some adjustments to the exercise to um, for your pain to be able to fall back down in that 24-hour period. So you could reduce the sets, the reps, the specifics of the exercise. So you would just tinker with it a bit. You wouldn't eliminate the exercise completely. You would just make some adjustments and try again, going through some experimentation. Then number 3, the trend in symptoms over time. We would want to see that for a given exercise, week over week over week, that your pain would come down. So if it's a 4 to 10 pain for an exercise 1 week, 2 3 weeks later, maybe it comes down to a 2 out of 10, some sort of trend like that. Okay, now with this slide here, there's a lot going on, and this is essentially showing that what happens to our muscle strength as we age. So it's broken up into 3 categories: early life, adult life, and older life. And as you can see in that early life, from the time we're born until about age 30 or 35, our strength just naturally increases throughout our development. Then when we get into adult life, we'll see that our strength just naturally decline a little bit. And then as we get older, that rate of decline continues. And as you can see, there's a few different trajectories there. There's the light blue line where there's less strength loss versus the dark blue where it decreases quite substantially. But that range of strength it's essentially up to us. So if we're keeping active, if we're keeping strong, doing strength exercises, we can keep our strength quite high throughout our adult life and into older life. And this is important because we've got this parallel problem of, as we saw earlier, the risk of OA increases as we get older. In addition to, we've got this loss of muscle strength. So this is something that we can control. We can control our muscle strength to decrease the risk of OA associated with getting older. And this process of getting stronger, it works like this. So it's called progressive overload. And the chart on the left there, it shows this cycle of what happens when we do exercise. So as you can see there where it says training, that would be an exercise session. And from doing the exercise, you don't get better from doing the exercise. You get better from recovering from the exercise. So it says training, And then it says stress there. So that line actually dips down a little bit, indicating that we actually get a little bit weaker from doing the exercise, but it's the recovery and adaptation period where we get stronger. So that period could be anywhere from 24 to 72 hours, maybe even beyond, depending on the specifics of the exercise. But then once that recovery and adaptation period has occurred, our baseline has shifted up a little bit. So we're a little stronger, we're in a better position than we were prior to doing that training session. And then if we do that again, do a training session that's perhaps a little slightly more challenging, we go through that process again. Of stress, recovery, adaptation, we move our baseline up again. And we can keep doing that and keep doing that. And that's the process of progressive overload. And that's how we get, stronger and stronger as time goes by. And there's a story that can help to illustrate this. So the picture on the right, that's Milo. He's a 6th century Greek wrestler, and Milo is often considered the father of progressive overload because one of the things that he did in his training is he picked up this calf and he would carry it up a hill and go up the hill, come back down every day. And every day he would go back and he would pick up that same calf and walk up and down the hill. And that calf would get bigger and bigger and bigger as it got older. And eventually that calf was a full grown bull, weighing over 1,000 pounds. And Milo was able to carry the bull. If he would have attempted to carry that bull, full grown bull on day one, he wouldn't have been able to. So he had to go through this process of a little bit more and a little bit more and a little bit more. And that's essentially what we're doing when we do any form of strength exercise. That's how we get the benefits. And it's possible to start this at any age. So on that last slide, I showed you these various trajectories here. So at any point on this graph, we can intervene and alter the trajectory of that curve. So that's good to know. So whether we start when we're 30 or 40 or 70 or 80 or beyond, it's possible to continue to go through this process and get stronger. So when it comes to strength training, some of the targets, some of the muscles that can be particularly important for OA include the thigh muscles or the quad muscles. So they can act as shock absorbers for the knees, and they help to stabilize the knee. But what happens is with OA, through pain, we start using the muscles less. It can so the muscles can get weaker, and again, we're in this vicious cycle. So we need to find exercises and utilize some of the strategies mentioned earlier with navigating pain to make sure that we're keeping our quad and thigh muscles strong. Hip muscles, also very important. They're close to the hip joint, so very important for stabilizing and protecting the hip joint, but they also influence the alignment of the lower body. So the picture on the right there shows that the knee can move into different positions, different alignments based on the activity of the hip muscles. So very important muscle group. Mainly, it's the glute muscles, but there's some deeper muscles in there also. So lots of muscles around the hip joint that we want to target also. In terms of the specific exercises that we could do, well, here's where we have lots of options. So these are just a few examples, but there could be hundreds really of exercises that could be appropriate. We would want a combination of multi-joint compound exercise where we're using multiple muscle groups, several joints at once, but then some more isolation or some single joint exercises. So as I said, lots of exercise options, lots of possible combinations. So this is where working with a physiotherapist could be helpful to design an exercise program tailored specifically for you. So when you embark on an exercise program, here are some ways that you could track your progress. You can notice yourself thinking about your pain less. Perhaps your pain is lasting for shorter periods of time. Maybe you're taking less medication, or your pain is less intense. So you're decreasing from a 6 down to a 3. You feel more in control of the pain, or you have more energy to do exercise or other things that you want to do. So those are just some of the ways that you'll know you're on the right track with exercise. There could be lots of other ways, but as mentioned before, the important thing is that you continue on with the exercise program for a period of time. And as you do, these benefits will continue to reveal themselves. Okay, so we talked about this already, but weight loss, even a 10% weight loss through diet and exercise can result in a 50% reduction in pain, and even lesser amounts. So even 5% has been shown to be really, really beneficial. Physiotherapists aren't necessarily weight loss experts, so working with some other professionals, perhaps a dietitian, um, could be helpful to learn some strategies if this is something that you think would be appropriate for you. And when it comes to weight loss, there's a couple of factors at play here. Of course, there could be the mechanical stress of the increased load on the joint from the increased weight, but there also seems to be this altered metabolic profile, which results in some pro-inflammatory responses. So the inflammation can lead to increased sensitivity in the joint, but also the entire system. So it's increased sensitivity to pain. So the picture is a little bit more complex than just the mechanical distress of the increased weight. There's a little bit more going on with it. So just be aware that it's beneficial for a number of reasons to be a decreasing body weight. All right. So Patrick, in his webinar last month, talked to us about understanding pain. So you can watch that webinar on our YouTube channel. He told us things like understand pain so you don't fear it. You can be sore but safe. Um, Suggested strategies such as pacing ourselves and just practicing some different pain management strategies. So highly recommend watching that webinar. It's filled with lots of helpful information. Okay, so that was an overview of that first line treatment, the exercise or the education, exercise, and weight control. I'll briefly talk about some of these things listed in the second line treatment. I'm not going to talk about the pharmacological pain relief because that is something that would be something that you would discuss with your doctor. But I'll talk about the aids and the passive treatments. So in terms of aids, you could use things like knee braces, walking poles, insoles or orthotics, canes, crutches, walkers, those sorts of things. So this is certainly a case-by-case basis. It's driven by the preference of the individual along with some trial and error, but certainly a physiotherapist could help you determine which of these aids might help and which ones would be worth trying. Okay, and then some other things that could be used for symptom control, and these could be provided by a physiotherapist, or you could incorporate some of them at home. So things like a hot and cold pack, a TENS machine, which some people have at home, and a Dr. Ho device would be what we're talking about there, or some acupuncture. So all of those things can help with pain control, so that you could continue on with your exercises. They can be part of the entire treatment plan. They're not changing the underlying pathology of OA. They're not necessarily making you stronger, but they can be, as I said, part of the complete treatment plan. So something that you could discuss with your physiotherapist. Just want to briefly touch on some things that don't have good evidence base. So glucosamine and chondroitin are some supplements that, even though they're widely used, they don't have a whole lot of evidence to support their use. But some people do say that they notice a benefit from them. So they're relatively inexpensive and not any significant side effects. So it could be worth trying, but just be aware that there's limited evidence to show that they're helpful. And then there's some other things. There's a variety of types of injections, like hyaluronic acid, platelet-rich plasma, stem cell therapy. There's inconsistent conclusions about those. So they can't be recommended at this point, although they are offered. Some people do notice a benefit, others not. But just be aware that's where the state of the research is at the moment. You will see lots of different advertisements promoting various types of stem cell therapy and that sort of thing. But again, there's little research on the safety and effectiveness of these treatments. So some caution is certainly needed. And that brings us to the end. Okay, so just a quick summary here. As I mentioned, there is currently no known way of curing cartilage loss, so treatment is used to reduce symptoms and improve the function of the joint. And now we need physical activity because weakness and inactivity are huge risk factors for OA and making things worse. When starting an exercise program, try to avoid getting excited and doing too much too soon. Start low, go slow, and progress from there. And just trust the process because, as we talked about, you keep it up for months and months and months, you will start to notice some improvement. It won't be easy, but it will be worth it. It's safe to exercise even when it hurts. So it has to be acceptable pain, which is found through some trial and error, some experimentation. And one of the simplest things you can do is just a basic strength training program. Just a few exercises to target those muscles around the knee or the hip or both can be really effective. And you don't need to lose weight to do better, but as we talked about, it can certainly be helpful. So to summarize how a physiotherapist could help, essentially what we would do is we would help you manage symptoms to maximize fitness to break that cycle. And here are some acknowledgements, some resources, and some people that I use to help to develop this webinar. So you could visit some of those sites to learn a little bit more. And also, I want to make a quick announcement that we will be starting, InReach will be starting a new class. It's going to be a Zoom-based class, so offered over this, offered online. And it's going to be small group exercise and education class to teach safe and effective strength exercise and strength training. And it's going to be appropriate for people with knee or hip OA, but also for people who don't have that. Okay. So why it would be appropriate for a wide range of individuals who just want to learn how to get stronger and get healthier. For people 45 years of age and above, and each class is going to be just three participants per class, and it's going to be ongoing for a 6-week period. So it's going to be 2 times per week for 6 weeks. We're aiming to start in early March of this year. And the cost, you can see the breakdown there. It's going to consist of an initial assessment, $25 per class, and then we'll be doing a follow-up appointment, individual follow-up appointment at the end. So if you'd like to learn more about that, then get in touch with us. And then our next webinar will be taking place in March with our physiotherapist, Nadine Stunzi. She's going to be talking about exercise and cancer, how and why. So get in touch with us as we get closer to the date. We will be releasing more information on that with the Zoom link. So stay tuned for that. So thanks again for watching, for taking the time. If you do have any questions, comments, you can get in touch with us. There's our contact information there. And we would look forward to hearing from you. Okay, thanks again.